abnormalities are common in the first trimester of pregnancy, and for many of the abnormalities that we can pick, they are very severe abnormalities, and many of these are not compatible with survival. It's a very distressing time for the mother, because she's now got to the point of getting to 12, 13 weeks of pregnancy, and she's identified with a normal outcome, and then you tell the mother that the baby's got a major brain abnormality that's not compatible with survival. It's very upsetting for any mother. But it's much more upsetting for the mother if you give the same diagnosis when she's 23 weeks gestation. I think the evidence is clear from the published literature. If the mothers choose not to continue the pregnancy, if the baby is a lethal abnormality incompatible with survival, that they want to diagnose it in the first trimester, not the second. In Australia, if a diagnosis of a major brain abnormality is made at 20 weeks, the first question that the patient will ask is, why did you not pick it up at the first trimester scan? And I think that's a good question, and it's a fair and reasonable question. And I think the patient has got every right to ask this question. Because if you are systematic in your brain examination, you cannot miss these diagnoses. I have to be careful when I say you cannot miss these diagnoses. We are all human. We all miss diagnoses. We all make mistakes. But I feel that with brain malformation, the abnormality I'm going to say, if you just follow the guidelines that I share with you today, you are very unlikely to miss these major anomalies. I think it's important to break down brain anomalies into anomalies that you always see, sometimes see, and you never see. You will see that the list of you never see, and I have not included them all, is a very big list. And you say, Simon, all these problems you cannot pick up over the first semester. But these are all very rare abnormalities. And some of these abnormalities we don't pick up in the mid-trimester. In some of these abnormalities we don't pick up in the third trimester. In some of these abnormalities they're not even picked up in the neonatal period, they're picked up later in life. But if you look at the group, which will include the spina bifida down to Walker malformation and the Always group, these actually make up 2/3 of all brain malformation. So these are the abnormalities that I will focus on today, recognizing that 2/3 of major malformation can be picked up. ISUOG recommends 2 types of brain examination. The basic, and I'm going to go straight and talk about the extended detailed examination. You need to look at the cranium, make sure there are no defects of phallus, choroids, thalami, brainstem, cerebral peduncles, aqueduct of Silvius, intracranial translucency, cisterna magna. For every baby that you do a scan in the first trimester. There are 2 ways to approach getting this information. The first is to look at the brainstem. This is the largest black fluid-filled space. It looks like fluid, but it's actually brain tissue. When you do a vaginal scan, it looks like tissue, not fluid. So that is the brainstem, and that is number 1. It's the biggest. You then look at the next fluid-filled space, which is smaller, and this fluid-filled space is the fluid of the 4th ventricle, which is also called the intracranial translucency. It's the same thing. And this is the second black fluid-filled space of the intermediate size. And the last black fluid-filled space is the fluid-filled space of the cisterna magna. And the cisterna magna is really quite small in the first trimester of pregnancy. And this is the smallest. So it goes 3, 2, 1, or 1, 2, 3 on the sides. If you want more information, this is the anterior border of the brainstem, posterior border of the brainstem, choroid of the roof of the 4th ventricle, occipital bone, and then the skin and the nuclear translucency. So there are many lines and spaces. I recommend that you count spaces and check the descending order of sizes. Secondly, I recommend that for every scan that you do in the first semester, that you divide and create, which is called a quad. In my practice, it's called Simon's quad. So every sonographer produces this image for every scan that they do in the first semester. You see the midline phalanx, you see the fluid of the lateral ventricle, you see the frontal bone and parietal bone that are calcified, you see the choroid occupies more than 50% the lateral ventricles. The choroid looks irregular posteriorly. This side is smooth. This is normal to be asymmetrical. It is normal for it to be irregular posteriorly. The next section, down, from superior to inferior, is the cave velum interpositum. The next section is the aqueduct of Sylvius, and we measure the distance between the aqueduct of Sylvius to the occipital bone. And the last black groove for the space is the choroid, is the fourth ventricle, which is lined by the choroid. And then this here is the brainstem. So it's important to see these landmarks in routine imaging of the baby's brain. And if you take the single image and with the sagittal image looking at these black spaces, you will identify the majority of major structural abnormalities. It is important to understand that there is no cavum septum pellucidum before 15 weeks of gestation. And it's very important when you are taking a BPD and looking at the cerebral peduncles and the thalami and the aqueduct of Sylvius, you should have no choroids in view. If you have choroids in view, you are taking the wrong section. You need to be a perfect transverse section. And by looking at a perfect transverse section with no choroids, you will be able to pick up most babies with spina bifida because this whole structure is shifted posteriorly. So if we look at the conditions that you can pick for acrania, I think everybody in this room will recognize that this looks abnormal. But if you are a junior in training, you may be focused on measuring a crown rump length. You may be focused on measuring a thin nuchal translucency, and you may think that the profile looks okay. But if you are an experienced operator, you will see that this profile looks strange. So you may miss acrania if you only do a sagittal section. In the same baby, you look for a 4 quad. And when you look for a 4 quad on this baby, you come down to the clavicles. This is the clavicles here. The clavicle coming in. And now watch when you come from the clavicles superior. None of the 4 sections of the brain are visible. Nothing is recognizable. There is no calvarian bone, there's no phalanx, there's no choroid, there's no cave velum, there's no aqueduct of Sylvius, there's no fourth ventricle, there's no choroid. It is an impossible diagnosis to miss if you do a 4-section analysis. But it is possible to miss if you only do a 2D evaluation. This baby also has a dilated fourth ventricle, which tells me that it's likely that the baby may have a digardic trichoroid to explain acrania. We published a paper in 2018 where we reported a normal baby and all the different types and shapes of acrania in the first semester. Mickey Mouse, bilobular, foreshortened, elongated, like Bart Simpson, cystic, overhanging, which looks like an encephalocele, and then irregular. If you match these images of a bilobular brain, a foreshortened brain, elongated brain, cystic brain, overhanging brain, and a regular brain, you realize that there are many different appearances to acrania in the first semester of pregnancy. And I encourage you to read our paper that we published in 2018. We also reported the Turkish turban sign in 2020, and these may appear as cystic cavities within the baby's brain. And this frequently is related to amniotic band syndrome, where the brain sits in the coelomic space, or the face inside the amniotic cavity. If you look at this case here of acrania, the four sections that are abnormal is this section, this section, this section. But the fourth section shows a dilated fourth ventricle lined by the choroid. These are all examples. That's the brainstem, this is the fourth ventricle, and this is the echogenic choroid lining the roof. All of these babies present with 3 abnormal sections out of 4. All of these babies have acrania, but if they have a dilated fourth ventricle, it tells me that it's likely to be trisomy 13, trisomy 18, or digynic triploidy, 69 XXX. And therefore it's very important in these babies to get a karyotype result on the products if they choose not to continue in pregnancy. The other abnormalities we may pick up is encephaloceles. We reported the largest series of encephaloceles back in 2015, which were from 3 centres across in Chile, Russia, and South America, and Australia. We reported that 70% of encephaloceles are occipital, and that to be careful of the parietal encephaloceles, because these are associated with amniotic band syndrome. And also be careful that 11% of encephaloceles may be related to Neck-Gruber. So when you see the encephalocele, check for polydactyly and check the fetal kidneys, looking for cystic change in the fetal kidneys. An important condition to diagnose because it is autosomal recessive. So you go to work tomorrow morning, and the first thing when you look at, you see that there is slanting of the forehead. There is a reduction in the frontomaxillary facial angle. This is a very useful clue of holoprosencephaly and encephaloceles. The profile should be here. The second thing when you notice, when you look through the back of the brain, there's a defect in the skull. This is the aqueduct of Sylvius, cerebral peduncles, and this is the thalamus. You appreciate that the baby has an encephalocele. At 12 weeks and 5 days, it is much easier to see this abnormality at transvaginal scan. So that is just a straightforward encephalocele. You may also look with 3D volume analysis, and the patient will understand this image and this image much easier than any 2D image. This, however, is not just an encephalocele. This is a baby that has a posterior small encephalocele with a thin nuchal translucency and cystic kidneys, who has polydactyly of the feet and big cystic kidneys on both sides. This patient has got a single gene abnormality, most commonly an NKS1 gene mutation. And only exome sequencing will give you an answer to this. Therefore, it's very important if you make this diagnosis at 12 weeks, you will get your result of your WES by the time patient is 17 weeks. But if you make this diagnosis at 20 weeks of gestation, it is much, much later that you'll be making this diagnosis later, somewhere between 25 to 28 weeks, because so much counseling needs to take place. This is a baby who has a very obvious encephalocele at 13 weeks of gestation. It is very important that when you see this hypoechoic, that you need to turn up the gain. And when you turn up the gain, you see multiple bands extending across to the fetus in a baby who's got amniotic band syndrome. So this is a neurotube defect related to amniotic band syndrome, and this has got a very low risk of having a genetic cause and a very low risk of aneuploidy. When you scan this baby's brain, the first section of the brain is abnormal. Because normally you see a phalanx, you see the choroids, and then you see the fluid of the lateral ventricles. But in this baby, all you're seeing is the choroids seem to fill the whole head. There is no fluid. This is a baby, what we call as a dry brain. And when you rotate on this image on this baby at 12 weeks, you then appreciate that there's no fluid in the aqueduct, and you appreciate that there's a cystic lesion arising from the back of the brain. This is the brainstem, the NHI, and the head is extended. Why? Because the baby has got amniotic band syndrome, giving rise to encephalocele. So very important to increase the gain to see this. You need to be very careful about making the diagnosis of encephaloceles in the first trimester, because some of these may be not as bad as you think. In this case, you will see that there is a cystic lesion arising through the posterior aspect of the brain with herniation of the brain through here. This is 10 weeks and 6 days of gestation. This is the same patient back at 22 weeks of gestation who has a completely normal MRI. And all you can see is thrombotic change in the straight sinus, the tiny cystic lesion. But the posterior cranial fossa, when you look at this baby, is normal. So this baby started out what looked like an encephalocele. But as the pregnancy progressed, the encephalocele retreated and regressed. And this is referred to as an atretic encephalocele. Normal cisterna, normal cerebellum, normal fourth ventricle, normal brainstem. So you need to be careful by counseling patients very early in the pregnancy. On the opposite side, this is a baby who was at 10 weeks of gestation and had a simple cyst at the back of the brain. When I looked at the brain anatomy, I could see that the landmarks were normal. Normal brainstem, normal intracranial translucency, and a normal cisterna magna. But when you see the same patient 2 weeks later, you can see that 2/3 of the brain has herniated in the skull. So this started off looking very minor, then became very severe, and the previous case started off being very severe, and then became minor. So be careful with encephalocele. They can be very difficult in the first trimester. With this baby, I saw that there looked like to be an encephalocele at 14 weeks. When I looked at the posterior cranial fossa, I could see a normal shaped cerebellum, and I could see a normal choroid, and I could see a normal fourth ventricle. So I counseled the patient favorably. I offered invasive genetic testing, but I had nothing else to be worried about. I considered that this could be an epidermoid cyst. When I looked at the same baby back at 18 weeks, now I could see that she's got ventriculomegaly and a far more serious situation. But I could not see the ventriculomegaly at the first trimester, so there will always be limitations. In this baby at 13 weeks, I could see that the posterior cranial fossa looked normal. I could see a normal fourth ventricle. I could see a normal choroid bar, normal fourth ventricle. And when you see the same patient at 16 weeks of gestation, the lateral ventricles look normal, the posterior cranial fossa looks normal, and this baby simply has a cyst on the skin with no sign of any brain abnormality. This is a benign epidermal cyst. When you look at meningoceles, these are a benign finding for many babies. When you check, you look for all the landmarks, you see if there's any distortion of the landmarks, which is, you cancel these favorably. When you push, you see the cyst moving with the fetal head, and this is not a meningocele because this is outside the amniotic sac. This is inside the amniotic sac. We move quickly now in the interest of time. Buloprosencephaly is a very detectable abnormality in the first trimester of pregnancy. You have a single anterior monoventricle, one. absence of the flaps, 2, and sharing of the choroid across the midline. For me, this is an easier diagnosis to make than making a diagnosis of acrania or encephalitis. A very straightforward diagnosis to make at this stage. With regard to the cerebral fourth ventricle, it's important to look at the cerebral fourth ventricle, which is the fourth section. This is a baby with a normal fourth ventricle and a normal choroid lining the fourth ventricle. But when you look at the four sections in this baby, it's a normal first section, choroids, fluid, cave velum, aqueduct, it all looks fine. But when you look at the fourth ventricle, you see that the fourth ventricle is enlarged. Compare the normal fourth ventricle, this one, with the dilated fourth ventricle of this. This is a common finding in the first trimester of pregnancy. 50% of babies with trisomy 18 will present with a dilated fourth ventricle. The baby also has mitral atresia with VSD. In this case, the baby has got tachycardia, bilateral pleural effusions, short long bones, and a dilated cerebral fourth ventricle. This baby has got trisomy 13. This baby has got an increased nuchal fluid, a dilated fourth ventricle, cystic hygroma in the baby with monosomy X. This is a baby with a dilated fourth ventricle. The abdominal circumference is less than the first centile in a baby with digynic trichomy. This mother had NIPT at 10 weeks, and it was normal, low risk, because digynic trichomy will not pick up on NIPT unless you are using a SNP-based platform. You may also see a dilated fourth ventricle in a baby who's got normal chromosomes, who later, when you scan, turns out to have a Blake's pouch cyst. And this is the same baby at 31 weeks where fenestration has taken place. But it first appeared at 12 weeks with a dilated fourth ventricle. This is a baby with a dilated fourth ventricle, and when you bring the patient back at 20 weeks, you see that there's Dandy-Walker malformation, absence of the vermis, splaying of the cerebellar hemispheres, and elevation of the tentorium. But this is a diagnosis that we can only make later in the pregnancy. It may be that if we look at the aqueduct of Sylvius, if the aqueduct of Sylvius is absent, it is more likely to be Dandy-Walker malformation, whereas if it's dilated, it is more likely to be a Blake's pouch cyst. But we need more data to support this in going forward in the first trimester diagnosis of these abnormalities. So next I'm going to move on to, very quickly, is to cover ventriculomegaly. So if we look at ventriculomegaly, you will see the area of the choroids, and you measure to the area of the lateral ventricles. If this is increased, then we'll find that this is how we make the diagnosis. The reason being, we cannot measure the lateral ventricle. We cannot take a measurement from here and measure the lateral ventricular width. This only works at the mid-trimester, but not in the first trimester of pregnancy. I'm wondering if we could bring the live scan, if we can bring the patient in, if that's possible. So this baby here, when you see that there's dilatation of the lateral ventricles, you appreciate the choroid should occupy more than 50% of the lateral ventricle. But in this baby, it's less than 50%. This is the clue. Just check by bringing the patient in, the live scan, please. The patient's here. As you translate through this volume, it's here. Thank you. And we can see the choroids here with dilatation of fetal cerebral lateral ventricle. And this is a baby with aqueduct stenosis. You can see the dilated lateral ventricles, the aqueduct. And if we translate through this volume, we can then begin to see the communication through the foramen of Monroe, the dilatation of the third fetal cerebral ventricle. Here's the foramen of Monroe, the dilated third. So yes, this is an abnormality we can pick up early in pregnancy, and in this baby with dilated lateral ventricles with bilateral pleural effusions. So we can make this call. So be careful though, for many of these babies with ventricular megaly, it's only the severest forms of ventricular megaly that we can pick up. To finish up, don't worry about oral plexus cysts. For most of these, they are benign and incidental findings and of no clinical significance. But just make sure that the rest of the brain anatomy and the rest of the anatomy, particularly the hands and the heart, there are no features of trisomy 18. I've seen many babies over the years that present very striking choroids with cystic change, and people think it's a brain tumor. This is not a brain tumor. This is a benign incidental finding, and the cysts in the choroids disappear with time. I'm just going to say one or two words about spinal bifida before I go to live scanning. Oh, I don't think it's in this talk, sorry. I'll talk about it in my scanning. So in summary, central nervous system abnormalities you may detect the always and the sometimes group, and these represent 2/3 of abnormalities. When we do the live scan, I will show a 4-section analysis of the fetal brain, assuming it's a first semester brain evaluation. And do this when you go to work tomorrow morning for every baby that you scan. And do this when you measure the brainstem, the fourth ventricle, the cisterna magna, measure the size of the intracranial translucency, and measure from the brainstem to the occipital bone as a useful landmark in screening for spinal bifida. Thank you very much for your attention.